Well, as soon as we got out of the aircraft, the paramedic from Red Wing Fire approached us and said, we moved him over to the fire hall. We had a pulse for a very limited amount of time, and now he's back into an arrested situation. So we knew at that point again that we just need to grab our stuff and go in. Initially I was thinking, well, maybe he's got a pulse, we'll just be in and out transporting him. But as soon as we arrived there, he said that he had rearrested and that they were having problems with an airway and getting IV access, and so we just took our stuff and went into the fire hall. So, arriving in there, it was pretty obvious. They were doing CPR. Red Wing Fire was there, Zumbrota Ambulance was there, and then along with the Goodhue first responders, they were doing everything appropriate. They were just in a situation where they needed more assistance, and initially, my thought process was, he's probably somebody that we can resuscitate. He's the rhythm we were seeing, the downtime sounded like it was very short. We got an initial report right away that first response was there almost immediately, that he had been defibrillated. So my thought was, it'll probably a good chance that we'll have a successful outcome. But as things progressed and as we watched and as time went on, not being able to change that rhythm, not being able to get him out of ventricular fibrillation into a sustainable rhythm, some type of a rhythm that will actually generate a pulse, it just seemed like we weren't getting very, very far at all, and that the outcome probably wasn't going to be good. I knew that they had deployed the defibrillator, that it had been used. At that point to us, it really doesn't matter how many times. We kind of know the amount of time that he's arrested, and that's probably more important. The use of the AED is important to us, that we know what, a couple of rhythms that he could be in order for that device to be deployed. So it tells us a few things, but mainly just the fact that, that it had been deployed was our biggest thing. And then from their report that, it seemed like it was a witnessed arrest, that somebody from their first responder unit, worked right across the street, was able to run over there, immediately recognized what was going on, started CPR early. Those are the types of things for us that tell us, the likelihood of somebody being resuscitated. Ventricular fibrillation is something that we look at, and as long as they're in that rhythm, it's something we can treat, something we can work on. Not that it's any more likely, I think, to respond at some point, once it gets to be more of a fine VF. On the monitor, it was still showing us a nice coarse ventricular fibrillation, and that's what we were seeing. So initially getting there, the thought was, hey, this is somebody that, the downtime is getting to be, lengthy, but he's still survivable. Having, done this for a few years, it's something that I've seen many times, that it's still survivable. And especially once we started getting some of our equipment on and seeing him, doing, with the first responders doing CPR, he responded to that very well. His arms would come up to me saying, hey, they're perfusing him with CPR, but as soon as they would stop CPR to change and for someone else to start CPR, you'd watch his arms go down. Once we intubated him, put a breathing tube in him, the results we get back, called end-tidal CO2, were very good, especially for the amount of time he'd been down. That also was telling me that he was being perfused very, very well. Those are some of the things that we used when we, after we had done a few of the things that we initially do with every arrested patient. I made a phone call and talking to Dr. White, those were some of the things that I can tell him. I think in his mind he's thinking, okay, so why is he calling me? Well, as soon as I tell him we've done this, and now we're in ventricular fibrillation still, I can't get him out of it, but yet his end-tidal CO2, I don't remember, was in the 30s. And that he's, his arms come up when we do CPR, that to him says, all right, this is somebody we will continue to treat because he is viable. What we're seeing for perfusion tells us that we're doing well that way. We've given, we carry a lot of drugs, but the drugs that we would use in this situation, we've given a bolus of a drug that we normally give a bolus one time. We have a repeat bolus we can give, but it's much less the second time we give it. It's not something I'm thinking is, in my mind, isn't going to be the key. If I've given him 300 milligrams of amiodarone, what's 150 milligrams going to do for him? I've already given him lidocaine, which is another antiarrhythmic. didn't see much of anything for results with that. You know, we can convert him for a very period of time. We deploy the defibrillator, we shock his heart, and we immediately, you know, there might be a very small pause there just to see what it did, and we go right back into CPR. Well, anytime we would stop to check a pulse, after that, you know, the monitor showed us ventricular fibrillation. So we're trying to basically take the rhythm that we're seeing, ventricular fibrillation, and we're trying to shock the heart to wipe out any electrical impulse, allowing the heart to start on its own. And we're not getting that, you know, and what we are seeing is he goes right back into that rhythm that's treatable with a defibrillator, but we can't keep him out of it. Talking to Dr. White on the phone, he said, you know what you're seeing on the monitor, I really think at this point we need to give him another dose of amiodarone, which is outside of my protocol, but it's something he's very familiar with, and he advised us to go ahead and give him another 300 milligrams of amiodarone. And I think his quote to me was, if that doesn't get him out of it, nothing is going to. So, you know, I think I ended that phone consult with him and went back over, talking to Mary and the other people that were there. We actually had to get Red Wing Fire to go out and get their medical kit and bring it in, because we don't carry that much amiodarone. We'd already given, you know, ours, so we had them go back out, get some more of their medication so we could even give him a second bolus that large. We gave him that bolus, continued CPR, defibrillated him a few more times. Really didn't seem like that was going to do the trick either. At some point, and I can't remember if it was the second or the third time that I talked to Dr. White, you know, I ran through all the drugs that we'd given, what we were still seeing on the monitor. You know, the fact, you know, I think I said to him, you know, I don't know what else to do for this guy. You know, I'm uncomfortable in the fact that I haven't seen this before. You know, we're still doing CPR. His end tidal CO2 is still great. His arms still come up. He breathes on his own with CPR, but as soon as we stop CPR, his arms would go back down. He'd get more of an agonal respirations, ventilations. And you'd watch his end tidal CO2 drop. But as soon as we started CPR, you could watch all that come back up. The phone consult that I had with him, I said, you know, I don't know if there's anything else we can do. There isn't a procedure we need to do. You know, with what we're doing is the exact things we're going to do in the emergency room, there isn't any reason to transport him. And now we've been into this for, you know, at that time I was guessing sometime around an hour and 15 minutes. And I think I walked over and I said, you know, guys, let's stop CPR. So we stopped CPR and stopped ventilating him, and his arms just stayed up, and his end tidal CO2 didn't drop. But yet when I look at the monitor, we still had a ventricular fibrillation on the monitor, something that shouldn't be producing anything as far as a pulse, and should have very limited perfusion. So I put my hand on in his groin to check his femoral pulse and his carotid pulse. Couldn't feel anything, but yet now he's sustaining this, you know, his arms are still up and his end tidal CO2 isn't dropping. So something's telling me we're perfusing something. So I said, all right, go back to just ventilate him, oxygenate him, but we're not going to do any more compressions. But when I had my hand in his groin and on his carotid artery still, I said, you know, just do a couple compressions for me just so I can make sure my placement's correct, that I'm on an artery. They did a couple compressions and I could feel a good pulse with it. I said, stop compressions, and we still didn't have a pulse that I could feel. And the monitor's still showing us, of course, VF. So at that point, I said, you know what, hand me a automatic blood pressure cuff. So we put a cuff on him, and about the same time I did that, I looked over at the monitor, and then we had this, all of a sudden, this nice, normal sinus rhythm. And then at that point, yep, you could feel a pulse. Put the blood pressure cuff on him, heart rate's 80. And in my head, I'm thinking, great, you know, this isn't such a good thing. Now we've revived somebody who, in my opinion, can't survive this. You know, he's been down for an hour and a half. The likelihood of him, you know, walking out of the hospital or having any type of life, in my head, was zero. You know, and that was been my thought for the last, you know, half an hour, 45 minutes, that we're resuscitating somebody, but I really don't think that there's much of a chance that he's going to survive it. You know, I've seen I think once, other than this, when I do CPR and somebody would respond physically, that they would either open their eyes or that they would, raise their arms. But I hadn't ever seen it for that excessive amount of time. It just, to me, it can't happen, it can't be there. We talked about it for quite a while. And it wasn't until the next time we worked together, which I think was either the next day or 2 days later, when we were doing follow-up to just check and see how he did, what had happened to him. If there was, basically I was looking for some type of a, hey, he's deceased, he didn't survive. But to see, in the notes that, he's awake, responding appropriately. I think at that point he still had a breathing tube in, and the thought process was still, hey, he still has a long road. But even in my head was, okay, well, if he perfused well enough that his brain is still there, that he doesn't have this big anoxic brain injury, yeah, he could survive it. Still didn't give him a great chance that would be the outcome. Well, her and I worked together, seemed like for the whole month. Well, the next time we came back to work, all of a sudden looking in his records, he was down on the floor. And my thought was, well, is he down there because they're, withdrawing support? Is he down there because he's going to die? My thought wasn't because he's out of the ICU and now he's down on the floor because he's just rehabbing down there and doing his normal stuff. But starting to look through his notes, he's awake, sitting up in a chair, and we were like, wow, So Mary and Kathy and I went down and talked to him, and we actually found him sitting in the kind of the little family waiting area talking to his brothers, and he had an IV hanging there, and I figured I was going to go down, and they said sitting in a chair. I figured sitting there, very weak, but he stood up and talked like you and I. I mean, he told us stories about things that had happened 14 years ago, and like he was right there. And I still can't explain it. I still don't understand it. But that's it's one of those calls. It's probably the call of the year for me. Well, probably of my career, the top 5 of things that I've seen and things that have happened that, are just things that you'll never forget. But yeah, so we sat and talked to him. I don't know how long, maybe an hour, and I've had conversations with him since. And yeah, very interesting guy, and yeah, he'll tell you, he doesn't really remember much from that day, but he wanted to be filled in on what had happened, why things went like they did, why we didn't stop. Because we basically were very blunt with him and told him, we don't know why you survived, and in my head you shouldn't have. And his question I think was very blunt. He said to us, why didn't you stop? And I was like, well, because you had a rhythm that was still treatable, and something we were seeing that was very uncomfortable for us, as far as to say, hey, this guy's dead, even though he's breathing on his own and he's got a treatable rhythm, and what we're seeing still says he's perfusing. And so yeah, I can't remember all the conversation with him, but it was, yeah, he was very sharp as a tack, and I wasn't expecting that. In order for him, we say, how did this guy get to 90 minutes of CPR and survive it? Well, I think the first initial fast response of the first people that got to him, the fact that somebody on a first responder crew literally worked across the street, was able to run over there and recognize immediately that, hey, knew exactly what the situation was, and immediately started CPR. Somebody that doesn't have immediate CPR, their chances of surviving the injury, and not only that, we talk about this defibrillator and deploying this defibrillator. The longer the heart sits in the rhythm we call ventricular fibrillation, the longer it sits there, the less likely it is that deploying the defibrillator is going to be successful, that it's going to put him into a rhythm that will produce a pulse for us. So had he not had immediate bystander CPR, I think his outcome would have been different. I think living where he did was a big part of him surviving. He's in the system that's set up here in southeastern Minnesota, where you have first responders, and then you have either a BLS or an ALS level of ambulance that arrives and takes over care, and at the same time that those people are being sent, in this case, because it came in as a cardiac arrest, the helicopter was deployed at the exact same time. All of those things happened in this case, and I think maybe in other areas of the country or even in Minnesota, I don't think his outcome would have been the same. But if I were to say the one thing, I would say it was the initial interventions. So it was that CPR that he got almost immediately upon arresting, hands down. I mean, all the things that we do in the helicopter and all the toys we bring and the monitors and the drugs and the putting in breathing tubes, that's all great stuff. But we can't get to that point if we don't have somebody perfusing his brain with CPR until we can get there to deploy those devices. Hands down, that would be the number one.
So